Shukran. Assalamu alaikum. I should express my greatest gratitude and thanks for this very kind and very generous invitation. And I will speak about Atlantoaxial instability and what we should know in this subject. Of course, hint of anatomy, etiology, clinical criteria, radiological criteria, surgical decision making, including when to operate, the surgical threshold, the appropriate approach, and I will present a case of mine. The anatomy, the articulation between C1 and C2 is responsible for more than 50% of the rotational movement of the cervical spine. And we can see that the cruciate ligament is supporting the dens against the arch of C1. Etiology, Atlantoaxial instability can be due to congenital cause, and the most common is Down syndrome, trauma, odontoid fracture, or transverse ligament rupture, inflammatory as in rheumatoid arthritis, infection, Grisel syndrome, which is upper respiratory tract infection causing atlantoaxial rotatory subluxation, and it is more common in children. The clinical criteria, most of our patients presented to us asymptomatic. So pain and torticollis may be, neurological signs in the form of limb weakness and paresthesia or loss of sphincteric disturbance, vascular symptoms due to vertebral artery compression. The radiological criteria to diagnose this instability, we begin by plain X-ray, lateral and dynamic views to see the atlantodental interval, which is defined as the space in front of the dens to the posterior aspect of the anterior arch of C1, and the space of the available for the cord is the space behind the dens to the posterior arch of C1. Open mouth, AB view, and we will see what's called rule of spins, which is the lateral overhang, combined lateral overhang of the lateral mass of C1 over C2, and the status of the odontoid, whether it is fractured or osodontoidium. The atlantodental interval is considered abnormal if it exceeded 3 millimeters. The space available of the cord is considered abnormal if it is less than 14 millimeters, and the rule of spins, or what is called the rule of spins, is the lateral overhang, as I mentioned, more than 7 millimeters, with a little variation for children due to ligamentous laxity. CT is very important to assess the detailed structure of bone and to plan surgery. We should search for what is called ponticulus posticus for C1 and the high riding vertebral artery for C2. Ponticulus posticus is a Latin word meaning a small bridge of bone due to ossification of the posterior atlantoaxial, occipito-atlantal ligament, so it overrides the vertebral artery over the arch of C1. Most of the cases are asymptomatic, but it may cause compression of the vertebral artery, resulting in vascular symptoms, and hence it is called Kimmerl's anomaly. It comes to a very important surgical point when we proceed to insert C1 screw. As we know, C1 screw can be inserted in the conventional way between the posterior arch of C1 and the lateral mass of C1, or the direct posterior approach, and here ponticulus posticus carries a severe risk for vertebral artery of misjudged as a wider enough C1 arch, so you can go through directly to the vertebral artery. So its detection in the CT is very important for lateral mass C1. High riding vertebral artery is defined as C2 isthmus height less than or equal to 5 millimeters, or internal height of C2 less than 2 millimeters. It is present in 25% of the population, and it may duplicate in the presence of rheumatoid arthritis. So it is very important and very critical to find it and to delineate it accurately when you are managing for C2 fixation. In a very recent paper published in 2025 by Klebinovsky, he classified the high riding vertebral artery into type 1 isthmic when only the isthmus is abnormal and the internal height is normal. Type 2, when the isthmus is normal but the internal height is abnormal. And type 3 is isthmo-internal, both readings are abnormal. MRI is important for spinal cord compression, ligament tear, or soft tissue inflammation as in rheumatoid arthritis. For the surgical decision maker, most of our cases are asymptomatic, and we should emphasize there is lack of consensus to operate or not to operate. Although these cases has higher risk of neurological compromise even from minor trauma. So when to proceed for surgery? We should have clinical red flags in the form of myelopathy, sphincteric disturbance, or intractable pain not corresponding to conservative management. Radiological red flags, atlantodental interval more than 10 millimeter or space of the available for the cord less than 14 millimeter. The surgical approach, we should search for the reducibility of C1 over C2 preoperative. For reduced cases, posterior fusion is the choice, and Gould-Harms technique is the gold standard nowadays, C1 and lateral mass and C2 pedicle screw. Magerle technique, transarticular C1-2 may be used. Historically, wiring techniques, Galli and Brook, but they lack sufficient stability nowadays, so the gold standard is nowadays are Gould-Harms technique. For non-reducible cases, anterior odontoidectomy transoral before posterior fusion may be needed in cases with spinal cord compromise, especially if the space available for the cord is less than 14 millimeter. Our case is 70 years old female patient presented to us after falling direct on her forehead with displaced C1 and dislocated C1 to fracture dislocation. All the methods of preoperative reduction was failed, preoperative skull traction failed, intraoperative under anesthesia before incision failed, intraoperative direct manipulation of the arch of C1 with C also failed. So the solution was to proceed for occipital-cervical fusion between occiput C2, and I supplemented with lateral mass C3, but I discovered that later on that it was not necessary because the pedicle screw to C2 was very sufficient to reduce the case and to fix it very well. Actually, the rod after inserting in the occipital plate was very high. So I persuaded it through the pedicle screw C2, and during this persuading, C1 rotated and reduced nicely. So I was surprised for this movement, and my intention was to fuse in situ. I am not intended to have very nice reduction like this, but it came during persuading the rod of occipital blade to the pedicle screw C2. And this is a situation of the case after 3 years. She is doing very fine. She is now beyond 80s. And in a nutshell, asymptomatic cases with atlantoaxial dislocation with atlantodental interval less than 10 millimeter follow-up. For symptomatic cases and the atlantodental interval more than 10 millimeter, we should operate posteriorly for C1-2 for reduced cases, anterior transoral odontoidectomy, and they may also extend the fusion to the occiput for non-reduced cases. But always remember that the vertebral artery is your enemy, and you should read the CT thoroughly and search for what's called ponticulus posticus for C1 and high riding vertebral artery for C2. Thank you very much.
Thank you.